at Medicines from the Earth in Black Mountain, North Carolina in 2017. For more information on our conferences, lecture notes, and recordings, visit our website, botanicalmedicine.org.
Do you all see cancer in your practices? Everybody? Yeah? It's pretty unavoidable at this point. As unfortunate as it is. I think we kind of went into the some of the metaphors of cancer, kind of the analogy of cancer, right? We looked at the as within, so without concept yesterday. I'm not going to hit that again. But that's such an important piece. So we're doing Botanical Medicine Oncology here, Part 2. And yesterday we went through a lot of really, interesting components of the botanical end of things, specific herbs we can use, and things that have a lot of really good data on them. Plants that have, not just in vitro mechanistic research on them, not just animal studies, and they were really plants that had traditional usage data from China, and then also had randomized clinical trial data. And so that was what's fun about that information from yesterday's class, is that it's real information. It's very supportive. You can use it to back up what you're doing if there's questions. A lot of times patients just want something that they can say yes to their oncologist. Yeah, I want to do this, and here's the data to support it. And that's really empowering to both the patient and for the practitioner. So I want to talk about today 3 main areas. The internal biological terrain. It's our term for kind of what's going on inside the body and how we can assess that at the molecular level, looking at the bloodstream and picking up little bits of pieces and seeing what's there. Tumors shed a lot of material, as we will kind of look at what the tumor microenvironment looks like and get an idea of how the tumor as a living entity is interacting with its ecosystem, your body, and is exchanging materials all the time with your body through the bloodstream and through the surrounding tissues. And so tumors end up shedding these different things that we call them tumor antigens. They shed different pieces, the way that they metabolize glucose and produce lactic acid and ketones. That stuff is all being, shed. There's lots of different changes that occur around the tumor. I want to talk a little bit about modern biomedical cancer therapy. Basically radiation, surgery, and chemotherapy. And then now we have this, kind of surgence of immunotherapy as another avenue. And then also I want to hit on controversies, because again here the idea is alternative cancer care. And so everybody's like, don't take an alternative. We have data to support these modern therapies. You should be using these. These other things out there are just alternatives. And we talked a bit about this yesterday, but it's not that what we're doing is an alternative. And I don't think of what I do as an alternative therapy at all. I think of it as a primary therapy that can be used in conjunction with, in collaboration with, modern oncological therapies. So this slide's got a lot of information on it, but I wanted to kind of do a little compare and contrast of the TCM pathological factors. This is, from a traditional Chinese medical perspective. These are the ideas. These are some of the things that would show up in a cancer case. And these are the correlations that we could make between biomedical concepts and the TCM. And remember, these are not direct correlations. I'm not saying that one thing on the left column equals something on the right. I'm saying that you can draw some parallels and get information. You can enrich your understanding by knowing both sides. So we look here, blood stagnation, the idea that stagnant blood is a big part of what cancer is. Cancer is a coagulopathy. It's a place where blood vessels have grown in ways that are very tangled, and it's a different structure than our living body. The body in our healthy tissue grows in very streamlined, very clear, very structured ways, and in cancer it grows in very uncontrolled ways, and it just becomes a ball and a mass of blood vessels and sticky materials. So that's blood stagnation, and over here we'd call it hypercoagulation. And we'll look at some of the markers like fibrinogen, the precursor to the building of fibrin, that little fibrous molecule in the blood that sticks to the platelets and makes a clot. Those things. Cancer creates a lot of fibrinogen as part of its process. People who have cancer are at 7 to 10 times the risk of having a clot than normal patients, just because cancer is so hypercoagulating. Heat, damp heat, and heat toxins, these are all kind of forms of how heat, and we might think of inflammation of the body's process. Like I talked about on Saturday, heat and inflammation are very, they're very tied together, where there's this activation of energy, of inflammatory mediators that get involved in the tissue if you look at it microscopically. But if you look at it more from a macroecological perspective, you see more of the changes happening at the tissue level, where the things are getting red. There's literally like quickening of the blood, and there's more activity of the immune system, and people can get fevers. There's all kinds of things that happen, and these are all manifestations of heat. And then heat combines with dampness and creates this sticky hot stuff that's really hard to get rid of, and it's very damaging to the body. And then heat toxins are kind of these byproducts of that heat process, molecular pieces that we can see. So over here we have inflammation, phlegm and dampness. Metabolic disorders, folks who just eat phlegmy forming foods, lots of sugar, lots of sweet, leads to a sticky situation in the spleen and stomach, and that starts to get into our digestion, and our digestion becomes unclear, and we have this resulting phlegm and damp material, sticky, turbid material that clouds the functioning, the clear functioning of the digestive system and the rest of the body. So that's metabolic disorders. We talk about blood sugar handling issues, diabetes, metabolic syndrome. These are the places that we would see that correlation. Liver stagnation I talked about yesterday, and its way of, hepatobiliary dysfunction manifestations, hypertension, and of course it leaning over on the spleen and affecting the digestion that way. The Sanjiao, the triple warmer, this is in Chinese medicine, the fluid metabolism system. We can correlate it loosely to the lymphatic system. And so I kind of made that parallel for you guys here. And then the quenching network, which is like the essence of our body, our adrenal essence system that quenches free radicals, creating compounds that go out and take care of those free radicals that would damage our tissues and instigate inflammatory processes. We're always shutting that down. We're constantly making materials to quench those little fires, and when that gets weak, we get into trouble also. Redox coupling and antioxidants, that's the parallel. And then over here, deficiencies, organ networks, deficiencies like kidney yin deficiency, resulting in night sweats and hot flashes and ear ringing, dryness. It would be one type of deficiency. And then the deficiency of essential substances, blood deficiency, marrow deficiency, essence deficiency, body fluid deficiencies. These are all, deficiencies of substances. And then there's also deficiencies of qi and deficiencies of yang, of that yang energy. These would be kind of correlated with the complete blood count, seeing things like anemia, neutropenia, where formed elements in the blood are deficient. The bone marrow can't make enough of them to meet demands. And so then those levels start to get below what we look at as normal and healthy. And the reason I put these up here is because remember we talked about yesterday about the importance of gathering up all the information we can. And even if you're not trained in how to read blood work or understand what are all these pieces, really slowly over time, you just take a piece of lab work, you look at it, there you can see at the top you've got red blood cells, you've got hemoglobin and hematocrit, that relates to iron and the heme molecule in the blood and how that relates to oxygen, carrying, transport in the body. That's all really important. Then you move into things like the mineral balance in the body. You can just see all these things laid out in the reports, the comprehensive metabolic panel and the complete blood count, which most patients will have from their first meeting with their oncologist. It's just very standard. Now, those tests don't look deeply at the little changes that are happening, like I'm talking about, like the biological terrain. They really kind of more identify organ failure. Like, is the organ failing? When you see the bilirubin get out of range, like if the range is 1.1 at the top, if it's at 1.6, the bile is not getting out of the bile duct and leaving the liver and going into the duodenum, and it's backing up into the bloodstream. And so it's showing up in the blood. That shows you that there's a problem, there's a blockage in the liver somewhere. So you just start to understand. It doesn't take that long just to go through the labs, get a good book to help you understand what they mean. You can look them up online as long as you're using a reputable source and looking at references. And you can pick up a lot of information. It helps. There's the complete blood count. One thing we like to see is the neutrophil to lymphocyte ratio. It's a really important piece of the immune function. The neutrophil to lymphocyte ratio is a good way to look at, differentiating whether you have a bacterial infection or a viral infection in somebody who comes in the clinic with some kind of a process going on. And if there's lots of lymphocytes, oftentimes you think, well, these lymphocytes are making antigens towards a virus, or antibodies, towards a virus, versus if they had high neutrophils, these kind of first-line defenders that are part of that innate immunity, then they're going to have more of a bacterial infection. And with cancer, the neutrophils always go high. Not in some of the leukemias and lymphomas where you get into blood-related disorders, hematological disorders, and it can be different. The lymphocytes can be higher, especially if the lymphocyte cell line is the beginning of the cancer itself, then the lymphocyte level will be high. But in most cases, the cell line is some tissue. It's a lung tissue, it's a kidney tissue, it's bone, whatever it is, and that cell grows and grows and grows. That we talked about it yesterday, how that process unfolds. But then the neutrophils that get involved in trying to destroy the cancer and take care of it, get it to shut down, they oftentimes become brought into the matrix of the tumor, and they become tumor-associated neutrophils. We get tumor-associated macrophages, tumor-associated fibroblasts. The tumor actually tells the body, I'm you. I'm you. We're all good here. I'm the good guy. And the body says, okay, well, you've got all the markers. You're telling me you're you. It's putting out these proteins that says, I'm good, because it is you. And the body's looking at it going, well, you got all the markers. Okay, we'll come and help you. So now you've got your own cells, your white blood cells, entering the tumor and actually supporting the tumor's function. This is a really interesting part of the process to understand, one that a lot of us don't. And when you look at the weight of a tumor, a huge component of that is actually our white blood cells. Macrophages, neutrophils, fibroblasts, all kinds of cells that are inside the tumor doing the wrong thing because they don't know better. So just a lot of tests you can see here, always getting into glucose and insulin signaling. This is a big piece. Those insulin-like growth factors lead to upregulation of cell signaling systems inside the cell, affecting the nucleus. The hemoglobin A1C, vitamin D, cholesterol. Looking at the urine pH we talked about yesterday and assessing kind of metabolic acidosis is really important. The hormone tests, these are all great, not only just in hormone-positive cancers, but because it relates to the reproductive and regenerative capacity of the body. So looking at these is really important. And these are good lists. Estrone sulfate is a test you won't see a lot of people run. The sulfate form, just like with DHEA sulfate, they're more accurate levels in the body. They're not fluctuating as much. 24-hour cortisol, these kind of tests are really good. Nutrients. The Nutri-Eval from Genova is a really good test for an overview of just lots of different nutrients in the body. I like to see copper, zinc, iron. I like to see MMA is methylmalonic acid. That's a vitamin B12 marker. Folic acid you can run. And these down here, the Dutch test is a 4-part dried urine test that is ordered through the company Dutch, and it's a $250 test to get the full reproductive hormone metabolites and the adrenal metabolites all together. And it's the metabolites, which is really cool. It's not just the hormone level. It's how does your body take testosterone, and then how does that testosterone get worked on? Does it get aromatized into estrogen? And then where does that go? Does the testosterone get acted on by 5-alpha reductase and get turned into dihydrotestosterone? And then where does that go? Does it get acted on further to become androstenediol alpha and beta? These are all pathways that we can understand to relate to the person and what's happening for them and how those components are affecting their cancer. And then we treat them with our herbs and our nutrients and our therapies, and we can monitor these levels again and see improvements, see changes. I really like that Dutch test. And estrogen metabolism. Where is the estrogen going? That's the big issue with estrogen, as an exogenous hormone that people take in. People say, oh, I'm just going to give estrogen, and estrogen has so many benefits. But again, it's where does the estrogen go? I always use the model of the pachinko game in China, where you put like a ball in at the top, and it goes down through a system of little pins that are inside the board, and it goes ding, 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 and then it comes out somewhere. And then when it gets to the bottom, it's like somewhere. You don't know. But that's how the hormone metabolism pathways go. They're steroidogenic. There's lots of them. They're affected by your genes and your enzymes and your emotions and other factors. And those estrogens can come out as 17 keto metabolites, for instance, which can be very proliferative. They can promote cancer. They can be very activating to estrogen receptors. These are cancer-related biomarkers. I don't want to get everybody too tripped up on trying to figure out what all these are, but inflammatory mediators are really important. Hypercoagulation. Glycolysis, when there's lots of lactic acid in the body, if in a cancer case, that cancer is turning a lot of sugar into energy and creating a lot of lactic acid as a byproduct. In lymphomas, this is a tumor marker that oncologists use. Lactic acid. Bone turnover. This is a really good one to start to tease out, is there cancer in the bone? And prostate cancer always wants to go to the bone. It's the first place you look. Prostate cancer wants to go to the bone. It'll go to the brain too, and can go to the lungs and the liver, but it's always first place you want to check is the bones. And so beyond a scan, you can look at these alkaline phosphatase levels, and you can break it out into an isoenzyme panel that looks at where's the alkaline phosphatase coming from, and there'll be a bone fraction. That's a good model, good marker. It's also the tandem R oxidase is the test now for this bone-specific alkaline phosphatase. These are urine tests. The telopeptides, they're bone turnover markers. So if the bone's turning over more rapidly than it would normally be, then you say, well, what's happening there? A cancerous process is a process where the bone is breaking down and rebuilding, breaking down. So bone components are ending up in the body and going into the urine. You could pick them up. Tests for cancer, these are really cool. Circulating tumor cells, things that you can follow over time. Oncoblot, this is a test, the ENOX2 protein. Oncoblot test is more of a yes or no question. Does the person have cancer or not? It's got a high degree of accuracy. It's a really interesting test that came available just like maybe 2 years ago. And then it's not available right now. They're doing like some kind of a re-establishment of their business structure. Somebody's buying them, I think, and it's kind of moving into something else. But very interesting to have a test that says, yes, you have cancer, or no, you don't. And this test is pretty darn accurate. It's like in the 90%. Yes, it is. Yes, again, it's like I'm talking about things that are shed from the cancer, right? The cancer is shedding pieces of molecular material, and this is one of them, the ENOX2. And a lot of cancers shed it. You can pick it up in the blood. They put these little chips down, and they run the blood across the chips. The chips has little probes, little nano probes, and the probes pick up things. They're little electromagnetic connectors, and they'll tell you kind of how much of a material there is in that blood. Tumor markers, these are all kind of for you guys to have. Always want to make sure that you look at these because they help you follow the cancer over time. How's the progress of this disease? Is the tumor marker rising? Is the tumor marker falling? And there are little nuances to understanding how it works, but I want you to have this list. These are tumor markers for the tissue. Again, just trying to get a lot of information. Is there progesterone receptors and estrogen receptors on the tumor? Remember I talked about breast cancer and how normal breast tissue has estrogen receptors and progesterone receptors on it. That's how the breast tissue responds in the body to what the body's communicating about how to reproduce. How much material do we want to reproduce? How do we want to affect the nucleus of those cells? Estrogen and progesterone are the primary reproductive hormones that will affect those tissues. So if the tumor that the person comes into you and they say, I've got a breast cancer and it's ER positive and it's PR positive, meaning estrogen and progesterone receptor positive, and everything else is negative, it doesn't have any epidermal growth factors that are positive or anything else they've tested, you know that tumor type is more like normal tissue than another one, and that's good. Normal tissue is expressing those receptors, and this cancer expresses those receptors. That means that it hasn't evolved so far from normal tissue. Do you follow me on that one? So if you had a lot of, for example, HER2, epidermal growth factor receptor 2, then that would end up saying to you that this is mutated away from the normal tissue. It's different now. And when it's different like that, it's more aggressive. More things here. Just take a look at these when you get a chance, and just take a look at it. These two tumor suppressor genes and this proliferation index, the Ki67, these are really important places, and our plants do a lot to help us, especially on these top two, P53 and P10. Our plants really do a lot to help keep these things strong, these tumor suppressor genes. Ki67 is a marker. You don't always see it in a pathology report when the patient first comes in, but you should always have it because it gives you information right up front. It has to do with the mitotic rate of the cells. How rapidly are they dividing? How fast are they going into mitosis? And the Ki67 will be expressed as a percentage. In these cells, there's a Ki67 of 10%. Well, that's not terrible. It's definitely there's definitely some activity going on. But if you get a Ki-67 of 80 or 90%, those cells are dividing incredibly rapidly, and that's a very aggressive tumor. So if a person's coming in and saying, "Hey, I've got breast cancer. I don't really want to do surgery, chemoradiation. I just want you to treat me, and I had a biopsy, and here's what I found out. It's ER/PR positive. And I just want to take care of it naturally. It's small." And you say, "Okay, well, let's get a Ki-67. Let's just see what it is." And that number comes back 60%. My advice to that patient is going to be like, we're going to need to be more aggressive with this thing because it's growing and moving so quickly that it could already really have spread. And remember that cancer spread microscopically. Cancer spreads in three ways, right? It can grow outward and extend itself. It can also grow into the lymph system, which happens very often, and it can also shed circulating tumor cells and circulating endothelial cells into the bloodstream. This can happen at a very early stage in the disease. This is why surgery alone doesn't work. And one of the things that happens is that the tumor itself generates a kind of a call and response with its seeds. So it's seeding the body with these circulating tumor cells, and then it has its own inhibitory signaling that tells those cells, just everything's good. The primary tumor is our primary site. It's growing. Don't go set up camp anywhere else. Just be there in case we need you. If you go in and take out that primary tumor, now all that inhibitory signaling is gone. And now those cells that are out there are like, okay, we need to get somewhere. We need to adhere to some tissue. I need to invade that tissue, and I need to start setting up a new satellite tumor. That's how, if you look at some of the surgical reports for how they study stage 4 cancer in animal models, you'll see that they will implant a known aggressive, a high Ki-67 tumor into a mouse. They'll let it grow for, a couple weeks, and then they'll go ahead and they'll pull the tumor out with surgery. Then they'll wait a couple weeks, and that tumor goes boom everywhere. That's how they get metastatic disease. P53, the guardian of the genome. This is that checkpoint. So as the DNA is being assessed before the cell goes into replication, there's places along the DNA strand that say, is everything okay? Is this all good? There's no mutations, right? There's no errors here. This is the right cell. That's supposed to be on. That's the P53 gene. And when that's off or mutated, more errors occur because it's not doing its job.
What plants intercept there, you said?
There's a lot of them. There's a ton of things that work with P53. That stuff will all help, absolutely. But big stuff like the isothiocyanates specifically, those sulfur-rich compounds from the broccoli seed and the cabbage and wasabi rhizome, those are really good with P53. There's a lot of our plants do affect P53 positively, and I think I have some lists of them in here. The tumor microenvironment, this is how the tumor actually creates its own ecosystem within the body. And it's this meshwork of extracellular matrix, the stromal material of the tumor, these blood vessel networks, and it's not just like this tumor is a little ball or an orb sitting in your body. No, it's networked. It's literally plugged in through the vasculature of your body. And what happens is you see there's all kinds of cells that are involved, fibroblasts, adipocytes, those are fat cells, endothelial and resident immune cells, growth factors and cytokines. It's just a factory of just creating this change in the ecosystem. It's creating its own ecosystem. It's very stagnant. It's very hypercoagulative. It has this involvement with the immune cells. It's very inflammatory. It's low oxygen. It's high sugar. That's what the tumor wants. That's what the tumor likes. So all the things that we can do to stop that, to change that, are going to help us. They're going to help prevent that cancer from succeeding. So non-malignant cells that get involved, endothelial cells, periocytes, those are cells around the vessels, fibroblasts, and immune cells all get involved in the extracellular matrix and the tumor microenvironment as a whole. So how does botanical medicine get involved? Well, like someone was just asking, turning on P53. P53 will turn on this thing called BAX, which will induce the cells to undergo apoptosis. So we can help the cells. A lot of the research I showed yesterday, a lot of the way that that's working, the plants are not actually just going in and like, bam, just destroying the cell like radiation would. The plants are actually just affecting the immune system and affecting the cells so that they're susceptible to apoptosis. So they go through their own cell death process. By changing what's happening in the internal terrain of the cell, we can get those cells to die. Matrix metalloproteases, these are proteases, protein, eating materials that break up the blood vessels and allow tumor blood vessels to mesh into our blood vessels. So this is another place that our plants can really help. Inhibiting angiogenesis, the development of new blood vessels, and reducing inflammation, which we hit hard on Saturday. Urine pH, I talked about how the glycolysis, that the way that tumors work is very inefficient. They take glucose and they ferment it, mostly anaerobically, although they can use an aerobic form too, but they create this energy, ATP, in a very inefficient way, and they create byproducts. They throw off ketones and they throw off lactic acid. Lactic acid is a big one, and just like in your body, when you overwork your muscles and you can't supply enough oxygen, what happens? Your body shifts to an anaerobic process that develops lactic acid, because every time you take a glucose molecule, you've got to make pyruvic acid out of it so you can run it into the Krebs cycle and generate energy. That process creates lactic acid. The cancer uses that exclusively. We use it only when we need it. Normally we can run through this really elegant process of, cellular respiration. So, glycolysis. Lactate, that's the big, this waste product. Like I said, you can measure that with lactic acid dehydrogenase. And you can also measure the urine pH, because when the body tries to buffer against this, the buffering materials will get depleted and other tissues will suffer. You can't change the pH of the blood, but the body can get depleted trying to maintain the pH of the blood. Tumor acidity attends with aggressiveness and metastases, and this is where you can use things even like sodium bicarbonate. You see the baking soda has been a cancer cure for a long time, and I'd say it's not going to cure your cancer, especially if you have kind of an aggressive renal cell carcinoma or something, but it will do a nice job of inhibiting metastases. It does slow down the process of those cells going to other parts of the body, and that's been proven out in a number of good studies. So when we get into lactic acid, you've got the things we can do using adaptogens, controlling helping the adrenal system adapt, using bicarbonate itself. Most of the time I don't like to use sodium bicarbonate because it's a lot of sodium when you get into higher doses, but potassium's a really good place to go. Magnesium bicarbonate, these are all good ways to go, and you can use bicarbonate to start to add buffer to the body so that the body can neutralize the acid. Quercetin, that's from the skins of apples and onions and things. It's a really nice plant flavonoid that helps stabilize mast cells, reduces histamine, and also can help get rid of lactic acid. Fruits and vegetables, just getting your patients to eat lots of fruits and vegetables, and celery juice. I have people use urine pH strips. I talked about these a couple times this weekend. Maintain their pH for a while up above 7. You can push it up to 7.5. There's some systems of using sodium bicarbonate will push it up to 8 for periods of time and then take it back down. You've got to make sure there's enough potassium in your body for that to happen. But again, you're changing the way that the body can deal with the lactic acid. So blood stagnation, coagulopathies, here's our relevant lab tests: fibrinogen D-dimer, plasminogen activator inhibitor, and inflammatory markers, because inflammation and coagulation are tied together, they're paired. Both of them will make the other one get excited and accelerated. So when you have inflammation, you're more at risk of hypercoagulation. Does that make sense? Yeah, nodo ginseng is one of my favorite plants for sure for maintaining the stability of the body's fibrinolytic system. It helps. Its category of herbs is to remove blood stagnation to stop bleeding. So it's bleeding due to blood stagnation, and that's kind of a longer story. But yes, sanchi, wonderful herb in here. Here's a couple groups of herbs to invigorate the blood. Then I have herbs to promote the blood circulation and remove blood stasis. There's turmeric. There's the Polygonum cuspidatum with resveratrol, cardamus, and there's Salvia miltiorrhizum we're going to talk about here in just a couple hours here with our panel. And then breaking blood stagnation, here's the shui zhi, the leech, which has the hirudins in it, right? When the leech is on the body and it needs to take blood from its host, it can't take blood if it's all coagulating. So it has to release heparin-like compounds to stop the bleeding. And so it reduces the coagulation, and that process we can, kind of exploit it by using the leeches themselves. And they've been used as an herb. They're grown, and then the leeches are dried, and then the leeches are powdered, and they're put into formulas, and they're used in the body to create this breaking up of the blood stagnation, or the reduction of that clotting cascade with those hirudins. There it is. So 14 different anticoagulants have been obtained from leeches. And I do use this in the clinic. I have this as a granule formula. It's a 5-to-1 extract of leeches. I'm from Minnesota too, so I have a personal, connection to leeches. Coming out of the lake. Oh my God, they're all over me. Yeah, right, exactly. Shh. My Minnesota leech farm. Specific inhibitor for thrombin. Thrombin leads to clotting, similar to heparin. So some other fibrin-digesting enzymes, these are all really important for the blood stagnation aspect. And one thing that happens is that when the tumor cloaks itself in fibrin, and it becomes hard for the immune system to see it and to adapt, to be able to deal with the tumor. So when we eat up that fibrin web with all these enzymes, that helps a lot, and helping to eat up the fibrin in the blood. And the coolest thing is that all these compounds are much safer than the stuff that's being prescribed most of the time, because they don't do anything to stop the process of clotting. They don't go in and affect the clotting cascade. Like I talked about turmeric, right? The curcumin incident that happened out in New York. Some plants affect the factors involved in clotting, but these compounds, they eat up the fibrin in the blood. And if there's no fibrin, then they're not eating it up. They don't affect the clotting cascade in the same way. They just eat fibrin in its presence. Lumbrokinase comes from the earthworms. Those earthworms have to digest the soil somehow. They use an enzyme, lumbrokinase, and it's been extracted, and we use it now. There's some good research on lumbro for you guys. Bromelain from the pineapple. Bromelain's really good. I think it's more good for the swelling and that kind of for helping to eat up the fibrin in these places where you get swollen tissues or joint damage. When there's even with ascites and things, swelling in the brain. Bromelain's really good for the swellings. And lumbrokinase is even really good for the tumors, for kind of having anti-cancer effects. Nattokinase from the soy miso, where you put the natto and you get the microbe to interact with the soy, and you create this culture. That's the natto miso, and this will cleave the fibrin inside the body. And here's our dose: 300 to 900 milligrams per day, and divided doses between meals. That's a high dose of natto. Even 100 milligrams 3 times a day is helpful. But for cancer, you got to get the doses a little higher. I think I put here 1,000 to 1,500 for the bromelain, and for the lumbro, 80 to 200 milligrams per day. So you have dosing on there if you need it, okay? And when you take these enzymes, they're between meals. They're away from food. I go at least an hour before or 2 hours after, which is tricky for cancer patients managing a protocol, but it's worth it. And then some patients do get a little GI issue. Like once in a while, the enzymes just are hard for them. You just take it with a lot of water. Just make sure they drink extra water when they're taking the enzymes. So we've got to address metabolic issues. We talked about exercise. We talked about dietary control. We'll get the diet stuff real specific. For helping those insulin-like growth factor receptor issues, we can use berberine. We can use chaparral with that nor-dihydroguaretic acid, its main compound. And these are plants that will help to synergize with the body in keeping insulin and glucose signaling working really well and keep that blood sugar down. Reducing blood sugar is really important for us. And adipocyte hormones, these are, just getting people to lose that extra weight through natural means, changing their diet, exercise, using herbs and nutrients. So phlegm and dampness syndrome, this is something in Chinese medicine that's, when people they're really kind of, their body's gotten soft and they've gotten kind of puffy, you can see that there's this phlegm in the body. It's just the fat cells become an organ. They're an endocrine organ secreting hormones, those leptins, adiponectins, resistin, aromatase. These affect the whole body, and you get caught in a cycle of, fat-making machinery keeps going in your body. And so we have to really work hard to turn that around. It's not easy because it's generating itself. So phlegm-forming foods, I've got milk. You got a bowl of cereal here with milk, grains that are processed, and bananas. And bananas are very phlegm-forming. So if a lot of people can eat bananas as long as they're in a state that their body's metabolizing things really efficiently. But when that metabolism slows down and you're caught in a place of, your body really wants to take any sugar that comes in and make fat out of it, you have to work a lot harder. So and it can be frustrating for a lot of patients. And we just have to be patient and work through it. But changing this is really important because phlegm gets in the way of the body's clear functioning, especially the immune system. Citrus peel, Poriococcus, Pinellia. These are phlegm-resolving herbs that will help to resolve the phlegm by drying it up and transforming it in the body to regulate the qi. Remember, we talked about yesterday about the life force and how important the qi is, right? The body wants to keep itself healthy. The life force is there to take the body through all the steps it needs to go through to maintain this harmonious, healthy, happy, feeling good body. And when there's a lot of phlegm in the body, when there's dampness, when there's heat, when there's cold, when there's stagnation, it's not working efficiently. So we have to free flow the qi mechanism, get it moving. And this is part of it. Eat up the phlegm so that the body doesn't get that stagnant block from the phlegmy material. Yeah, it is. This is an easy one to get. This is the 2-cured decoction, Archen Tong. And the Tong means a decoction. You can use Wan, Archen Wan, which is a pill. And you can get it from Mayway, you can get it from Spring Wind, you can get it from Con Herbs. They'll have it in a little tea pill, and you can take that tea pill every day for a person that has those issues we're talking about. And a dose of the little tea pills that are about 200 milligrams would be somewhere like around anywhere between 12 and 20, 3 times a day. They're little teeny pills. You can get them in 1,000 pill bottles, and they work really well. They're really nice. And Mayway and Springwind, they do a really good job of assaying their materials, making sure that their herbs are not contaminated with any metals or any molds or anything like that. So, great question. So let's talk about the cancer therapies, because most people that we interact with are coming in and they're doing chemotherapy, they're doing surgery, radiation, they're doing immunotherapy, and they want help. Because, like I said yesterday, it's really sad when a person is getting a powerful response, meaning that the cancer is responding to the therapy they're taking, to the chemotherapy, but their body is getting so beat up by the therapy, their bone marrow is getting so suppressed that they can't handle taking the therapy long enough to destroy the cancer all the way and get us to that no evidence of disease state. That's really frustrating. So our job is to say, I'm going to hold you together. I'm going to keep your body together during this process so you can get through the therapy. That's one thing we can do for people. So you look here, you got cancer and cancer treatment, and you can see here's our 4 different tools, right? Surgery, radiotherapy, chemotherapy, immunotherapy in modern medicine. And what does that lead to? Well, it leads to all the same things that cancer leads to. These are very depleting, very catabolic processes that we use to treat the cancer. And this is where it gets really difficult. And if you look on the internet and you look around, you'll hear people saying, chemo's terrible, it kills you. Radiation's terrible, it kills you. Herbs are the way, and you need to do these fasts or things like that in order to cure your cancer. We got to support the life force and build the body. That's how to get rid of cancer. And it's true. I mean, on one level, I hear that 100%. But like I said yesterday, if people aren't willing to reduce the stress in their lives, change their existence here, if they want to go live in a cave, have somebody bring them water and pure, juice every day, and just meditate and pray and take herbs, that's one thing. But that's not going to happen for 99.9% of your patients. They're going to come in, they're going to want to keep living their life and be with their kids and go to school and do their work and maintain their house and da-da-da-da. All that stuff is, you can't take that away, the stress of all that. It makes it hard. It's hard to work through that and work through cancer. So in that case, we oftentimes need a little help from these areas. All the things you see, cachexia, this is just not getting enough nutrition, the body starting to melt away, the spleen energy, the muscles, everything starts to waste. Anorexia, fatigue, depression, neuropathic pain. These are all things caused by cancer and the cancer therapies. So I just want to reinforce, we're trying to talk about how we can stop these things from occurring in our patients with our therapies. So surgical trauma, I talked a little bit about how, just when you take out a tumor, you don't want to just have the person come into you after their surgery and say, I just had surgery, I'm good, now my tumor's out, can you help me? That's not ideal for us. We want the person to come to you and say, I'm thinking about, what are my options? And I might do surgery. What do you think? And you say, okay, great. Let's get some information. I'll do your constitutional assessment, all that. We'll get some blood work. Let's see what's going on. We'll apply our therapies. Let's give you a few weeks. 3 weeks would be great. If we could just take 3 weeks. Most of the time, there's no rush. Cancer's not a rush. Oftentimes it's treated like a rush, but these are chronic diseases that take a long time to develop, and they take a long time to get moving into the aggressive stages. There are, of course, exceptions, so you want to make sure and know that. But it's very, very highly likely that if you take those 3 weeks to rebuild their body, get their adrenals stabilized, get that coagulation under control, tamp down the inflammatory fires that are going on, what you're going to do is you're going to have that person go through surgery, and they're going to get way less deficit out of the anesthesia, out of the process, and when their body tries to repair from the damage of the surgery with promoting all kinds of growth factors, the fibrinogen that's going to be created, the fibrin, all the clotting that develops out of it, all those growth factors that are needed to rebuild the tissues, all that stuff not only promotes cancer, but it's also really hard on the body. So what you can do is get those markers all stabilized, get the terrain into a normalized state, and support the body. And then when they go through surgery, it's so much easier for the body to maintain this balanced state in the, inside the bloodstream, inside of all their systems, their tissues. That's so important. It's really it's hard because, like I said, the patients mostly come to us after the surgery, not beforehand. And so, of course, you just do your best and try to get things under control afterwards. But it's ideal when we can see them beforehand. We talked about the circulating tumor cells and how surgery can be a problem in this area. I mean, Eli Jones, Donnie's favorite cancer doctor from right around 1900, right in that area, he spent 50 years treating cancer, and he said, "I don't want to cut any more cancer out of people." He was like, "It's the worst thing ever. I watch these people get their cancer cut out, and then the cancer goes everywhere." And that's the deal, is that if people sometimes you want to get the cancer out. I've got cancer, I need to get it out of my body. I just want to get it out. And I can understand that. I mean, I totally hear what that, in my body, I know what that feels like. But that's not the smartest way to go about it. Most of the time the oncologists are thinking, hey, we're going to take the tumor out, we're going to give you chemotherapy, we're going to radiate it, so it doesn't matter. That's what they're thinking. They're thinking that they're going to do all their therapies. There's something called neoadjuvant therapy, and that's where you give the person a treatment, a targeted growth factor agent that targets a pathway, or you give them chemotherapy. You give it to them before the surgery. That's neoadjuvant. And then what's interesting about that is that you can see whether that is having an effect on the tumor or not by looking at the tumor itself and seeing, does it shrink, or is it stable, or is it still growing? Now, if you take the tumor out and you remove it, which is the standard of practice in most oncological institutions, is that you pull the tumor out first and then you do the chemo, based on clinical trial data. That women that had a cancer of the breast that was around this size of these people, then I would give them this chemotherapy, and pretty much these are the outcomes, and we'll just go with that. I'm not answering your question quite yet, but I'll get there. So, doing the treatment beforehand tells you in vivo whether it works or not. And that's really helpful. And then if it doesn't work, you can switch your therapy. And if it does work and it shrinks the tumor down, then the surgery that the person goes through is a lot smaller because the tumor's smaller. And then you know that chemotherapy you were using works. So you can keep on doing it. So even if there are circulating cells, it'll still affect those cells. And remember, when a metastatic cancer occurs, those cells are not, if I have a kidney cancer and it goes to the bones, those aren't bone cells, those are kidney cells. If I have a breast cancer that goes to the brain, it's not brain cells, those are breast cells. They're growing in the brain. It's the same cell line. Remember I said it's one cell line. Now the population of tumor cells they're not homogeneous, they're heterogeneous, which is really important. And this is why a lot of the oncological therapies fail our patients. And where we can help with our botanical medicine is because it's not like you're going after one single cell that's it's perfectly the same every single time. Once in a while, there are some homogeneous tumors that are more simple. They're more kind of like what Donnie used to call baby cancers. But most of the time, it's sort of like the microbes in our body. There's a competition between different organisms that are trying to sequester resources, and they're in this sort of flux, trying to work against each other or with each other, however you want to look at it, to kind of hold their niche within your ecosystem. It's the same thing with the cancer. Different cells within this cancer have mutated under all those. We talked about the tumor microenvironment. It's a rich environment for this change, for mutation to occur. All these different factors, all the inflammatory stuff we talked about, these are all inducers of mutation, especially in a DNA that's already damaged and mutated. You start to get cells that have different attributes. Some cells won't respond to the chemotherapy that you're using on a patient or that the oncologist is using, and what will happen is that the primary tumor population, let's say you biopsied it and you got some information and then a chemotherapy was applied and then the tumor shrunk. Well, what if part of that cell population just already had a mechanism that just it got rid of that chemotherapy. Chemotherapy didn't affect it. Well, then once the main tumor population gets damaged and shrunk down, then this other population, the smaller one, which is not being affected by the chemo, is like, whoa, freedom. I can do whatever I want now. I've got free room for resources, and this chemo doesn't hurt me, so it starts growing. This is where you get chemo resistance. That's why chemotherapies don't work for very long, and why targeted therapies don't often last. It's so interesting when these targeted therapies for melanoma came out. It was so exciting because everybody got well. It was like, oh my God, this is amazing. We just cured cancer in these people. It's like 10 years ago. And then 6 months later, all the people were dead.
Yeah, and to that point, the tumor cells are not homogeneous. You have progenitor cells, cancer stem cells, that turn on epithelial mesenchymal transition, which is the metastatic, activating transcriptional factors which are driving that. And some of these plant-based molecules can target those things. They're difficult because they don't have the receptors on them. When they change form, these epithelial mesenchymal transition, they change tissue form, and they don't have the receptors on them, which makes them difficult because they're not easily targeted.
Right.
That's the problem with chemotherapy, as you said.
I think he's just reinforcing the idea that these are not homogeneous and that there are cancer stem cells and then there are progenitor cells, daughter cells. And chemotherapy damages the daughter cells and doesn't damage the stem cells. And this is a big place for us because our plant-based molecules do help the immune system to stop the stem cells. So again, when you combine our therapies with modern therapies, you get that benefit of being able to damage and get rid of both types of cells. If you don't do the stem cell stuff, you get rid of the tumor, but there's still circulating stem cells, they're going to set up camp and start a whole new daughter population.
That's the key to also triggering your CD8 cells and targeting anti-tumor immunity.
Absolutely. Here's some anabolic enhancing plants. Rapunticum, ginseng, tribulus, uricoma, epimedium, pantocrine, mumi, royal jelly. All these things are very anabolic. These are going to help the body to rebuild and regenerate. So when we calm the inflammatory cascade, we start to help the body be able to regenerate. But then we can also use plants that directly help to build tissue. And remember, these plants, when you look at the data we have on them, whether it's animal, whether it's historical, if it's in vitro, these plants have cancer inhibiting activities. These are not going to promote the growth of cancer. So here's just a list of chemotherapies. I don't want to get too into this, but alkylating agents, platinum drugs, taxanes. We have anti-metabolites, like the 5-FU we talked about yesterday, Xeloda. We've got antibiotics. These are the cyclines, like doxycycline, anti-mitotic agents, things that inhibit mitosis, and miscellaneous type of anti-neoplastic agents, of which there are a number. There's like 30 primary chemotherapies right now. And there's more kind of that are just extraneous, but you've got the mustard gases, and there's lots of different avenues, and it's a lot to study. I don't want to try to get into it right now, but it's worthy for you to, if a patient comes in, dig in and find out what their chemo regimen is, and then find out how those chemotherapy agents affect the body, and then you can support them more directly. And hormonal therapy, which often people just think of it as chemo, but it's not. Tamoxifen, which blocks the estrogen receptors. Aromatase inhibitors, which stop the conversion of testosterone into estrogen to help reduce estrogen levels. These are hormonal therapies. Chemo side effects, a big list. Lots of different things. And this is a resource for you. Like I was saying, you want to look up, well, what happens when someone takes Cytoxan? Well, they're going to have bladder issues. You get the cystitis. That's really a big problem. It can be bleeding. So you want to protect their bladder. Use herbs that direct to the bladder. Most of the chemos have neurological impacts, so we want to protect the neurological network. Increased risk for thrombosis, right? Blood stagnation resolving herbs. Those enzymes we talked about. And I kind of listed some things here. The platinum drugs and their kidney damage. They have to be renally excreted, so they end up damaging the nephrons and damaging the kidneys. That's hard because we lose our mineral balance. With platinum drugs, you always want to give people potassium and magnesium. It's one thing you can do. Alpha-lipoic acid is fantastic for neuropathy. Common symptoms, the cells of our body get damaged by the chemotherapy just like the tumor does. So they get really deficient and depleted. our platelets. Like I said yesterday, those essence tonifying herbs help with build up those platelets again. Neutropenia, the Dongui Bushui Tong, that angelica decoction to build the blood. It helps to build those white blood cells and red blood cells. Anemia. Mucositis and diarrhea, constipation, GI toxicity, those anti-metabolites like Xylota and 5-FU is really hard on the mucous membranes. They just make everything fragile and dry up. You start having all kinds of issues and mouth sores and in the GI tract and that whole tube, you start to have this breakdown, these ulcerations of the tissues. So you do lots of demulcents to support that. Really try to get that mucus layer strong. One thing was happening with alopecia because, our hair cells are dividing really rapidly. And so because chemotherapies they're not specific always to a part of the cell cycle, but they damage cells that are in cellular division. They're within the process of synthesis or growth. They're not in a resting state. So resting cells don't get damaged because it's undergoing, when cells go through the process of replication through mitosis, there's a lot of things that happen, right? You form these centromeres, there's microtubules that connect the centromeres together, the chromatids are formed, the cell goes through all this transition, and it's those steps along the way that chemo targets. So it might maybe like the taxanes from the Pacific yew extract, the taxanes that were originally developed from the yew tree. Those will inhibit the microtubules from separating in the middle of the division. So the cell's in the process, it's got all this genetic material separated, it's got the microtubules, it's ready to go, and taxane goes in and damages the microtubules so they can't separate. And the cell just dies. So hair cells are also dividing rapidly. That's why we lose our hair. And so there's some really interesting recent research that came out showing that cold caps that can be kind of really specifically developed for the patient can keep the energy really cold here, and so reduce the blood flow to just the surface area tissue, and it's preventing people from losing their hair. I have talked to oncologists who are worried that if you do cold caps, for the fingers and hands, if you're trying to prevent neuropathy from damaging those areas, or from the head, that maybe the chemo's not getting to those areas, and those could be metastatic sites. I don't think we have enough data down the road, but the research coming out right now from some group of oncologists is showing that this is really positive. And so just not having people have to lose their hair is a really wonderful thing. Like, hey, I want you to do a little chemo, and I'll help you with all my therapies. Let's do it together, and I'll keep your hair from falling out. That's pretty cool, because it's such a big sacrifice to go through the hair loss, when you're just, all your hair falls out and you go bald. Here's just a great solution to chemo side effect page for you guys. This is great. This is a resource. I don't want to go through it. It's a lot. But it's all there for you. Okay? Yeah, question?
I can't remember the name of the chemo drug, but after a lot of breast cancer patients, their hair is not growing back, and it comes back in really fine. Do you have any suggestions for that?
Again, a lot of hair-nourishing tonics. I always use, saw palmetto is really good. I like the beta-cytosterol, especially in men. I like the Fo-T, Hushu Wu, the Polygonum cuspidatum. I also like the thymoquinone from the black seed, the black cumin seed, Nigella sativa. Flaxseed oil, it's one of the only times I really like flaxseed oil. Tablespoon in the morning, tablespoon at night. You got to keep it in a dark bottle and keep it cold, because when you press it, it's already starting to oxidize. These are some of the things we can do. Zinc is a really important nutrient from hair growth, and some B vitamins, folic acid especially. If you do all those things, it'll help. Sometimes hair, when it grows back, it started out straight, it comes back curly. Sometimes it was curly and it comes back straight. It can be a little frustrating for people, but I've had people also be like, this is so cool, I've wanted curly hair my whole life. So, and it's just, when the hair comes back, it's a beautiful time. Nausea and vomiting, this is, if you've experienced nausea, then you know just how incredibly debilitating it can be. Just that feeling of just unease in your in your stomach, in your abdomen, and just that, oh my God, it's just terrible, like being seasick all the time. And it's one of the most common things that we find with people doing chemotherapy. And here's some of the things that we can do for people. Ginger, of course, and you can make strong ginger teas. You can take ginger caps. You can take ginger essential oil caps. You can do all kinds of different things with ginger, which in many cases is helpful. Essential oils of citrus, vaporized, breathing them in. You can put them in the house, just have them in little, emitters around the house, vaporizers, just to kind of keep that citrus. That's a very clearing, helpful. Like I said, the citrus kind of resolves phlegm and dampness, helps to kind of descend energy in the stomach. So those essential oils in the air are very helpful. Teas, peppermint, ginger, orange people, papaya, perilla. Hydration, keeping hydrated even though people don't want to drink. Because oftentimes when you're nauseous and vomiting and things, you don't want to get fluid, but you really need it. And don't forget about salt. Sea salt is going to keep water in your bodies, right? Water follows salt across the semi-permeable membrane. Vaporized cannabis, this is the #1 treatment for me for nausea and vomiting. Of course, I come from a legal state, both medical and recreational, so people can just get cannabis at the store, which is great. And I mean, there's just nothing that compares. And some people don't want to vaporize it. They can smoke it even, but if you smoke a little bit, it goes right into the lungs, into the bloodstream, and it just settles that nausea down. And then it also gets people eating. And so if there's one place that cannabis has a really strong role to play, it's in the management of nausea. And oral stuff, it can help in some patients, but not nearly as much as getting the vapor right into the body. And the marinols and the other synthetic cannabinoids don't do anything. They're terrible. We don't need synthetic cannabinoids. Acupuncture can be helpful, and I've got some TCM formula ideas, how we can help people looking at their pattern and trying to see how is their nausea manifesting. And then I put up here kind of a formula: the perilla leaf, pinellia, citrus, and ginger. The polygala, this is a really good one, kind of calms the heart and kind of calms that adrenergic part of the nausea issue. Heart stimulation, and then poria, and then the fructus amomum, which I've put up on a lot of slides because it's cardamom. It's a type of Chinese cardamom, and it's really helpful for calming down the middle jiao, the stomach and the digestion. Neuropathy, a big part of chemotherapy. This is especially with platinum drugs, taxanes, they cause neuropathy, and neuropathy can be very debilitating. And like with a drug like Abraxane, which is a really it's a form of taxanes, those Pacific U developed molecules that's bound to albumin and then used to treat cancer that way. And it's really interesting because it doesn't require steroids. Most of the time when you take chemotherapy, another aspect of what's depleting you is that you have to take steroids in order to stop your body from building a huge antibody response to the chemotherapy in your blood. Because the chemotherapy, you couldn't digest it. The molecules are too big. It has to be injected. So they put it into a vein and just run it right into your body. And that's how you stop your immune response, is by giving the person steroids. But those steroids also have a big, profound impact on your adrenal function. They have a profound impact on suppressing your immune system and your immune function. So Abraxane is interesting because it doesn't require any steroids. It's a form of Taxol that doesn't require steroids. And it's harder to get because it's more expensive, but it's a much better drug overall. And if you can recommend that to patients who are looking at a taxane therapy, it can be a really good way to go. But its dose-limiting factor is neuropathy. So we need to try and prevent the neuropathy from people. And so one of the things I was putting up here is a good human study on combining alpha-lipoic acid with boswellia, at methylsulfonomethane and bromelain together as a way to inhibit neuropathy and prevent it. Magnesium, B6, B12 and B vitamins for sure, alpha-lipoic acid, glutamine. These are all things that have powerful effects on preventing neuropathy. And we want to really focus in on that, like I said before, because if a person's going to go through the process of losing their hair and going through this therapy, let's get it to work as long as it can. Let's get them, let's try to give them as much of it as possible. You can see here 12 weeks, well tolerated, no increase in toxicity profile therapy, improved their CIPN symptoms. And I don't know if you know, I didn't put it up here, but there's a drug called naltrexone, which is an opiate, and there's a form of it called low-dose naltrexone, which is it's an opioid receptor antagonist, and it ends up blocking the opioid receptors. You take it before bed, and then in the morning there's a rebound flood of endorphins that comes into the body that really helps with the neuropathic pain. I've had folks that literally they couldn't live their life. They were just in so much pain after all the chemo they've been through that low-dose naltrexone just was like life-changing for them. I've had a number of patients, and it also has some anti-cancer activities as it affects the immune system. It's somewhere between 1.5 and 4.5 milligrams per day. Just throwing that out there as a little tidbit you can talk to people about if they don't know.
That's the one for opiate addiction.
Naltrexone is for opiate addiction, true. Yep, but that's the full dose, 25, 50 milligrams.
What was that substance?
Low-dose naltrexone. Naltrexone. Naltrexone.
Compound.
Yeah.
It's compound.
Yeah, it is. But you can get insurance coverage.
No.
You can? Oh, never? What state are you in?
Ohio.
Ohio? I'm pretty sure I've gotten it covered for several patients in Oregon.
It's not expensive in Maine.
It's not expensive in Maine either. I think it's a state thing. Yeah. It's a low dose. Anyway, so diarrhea, a big part of chemotherapy too, it can go either way for people. It can go to diarrhea, it can go to constipation. Some drugs, like irinotecan, lead to diarrhea in some patients based on their genetics. They could have life-threatening diarrhea. And this is one of my favorite just remedies. It works really well using bentonite clay with whole psyllium seed. And whole psyllium seed is one of my, I love that stuff. Using the whole seed, you put it in water, a tablespoon in 10, 12 ounces of water, let it sit for 10 minutes, it gets kind of gelatinous. Then you throw in some aloe powder and some bentonite clay, and now you create this conglomerate that moves through the bowel really smooth and easy and slows down that diarrhea and stops it for people. You can't do a ton of clay for a long period of time because it does strip out some of the bugs. It's adsorbent to everything. It doesn't choose the good stuff or the bad stuff. So you take it away from food and you use it when you need it for acute situations, but it works wonders. You can also take out the clay. So if the if the diarrhea starts to get better, you can reduce the amount of clay and be doing just the seeds, the psyllium seeds. It's not the husks, it's the whole seeds. And the aloe. Aloe has a lot of good activity, both anti-cancer and for soothing those mucous membranes. With radiation, we talk about, how can we help? Here's a great idea. Some of the components you can put together in a topical, and obviously you don't put it on right before the person would get radiation, but as soon as they finish radiation, you can apply it. You can apply it topically, and you can apply it 3 times a day. Just keep it going all through the day, and it will really help to reduce the damage to the skin and the surrounding tissues. With radiation, we're looking at collateral damage as a big issue. We'll talk more about radiation as we go a little forward here. Radiation and antioxidants. So this is one of those issues that comes up. I'm just going to try to break this down and share with you, what Subhuti Dharmananda brought up was that when you take a beam of radiation, a high intensity focused beam, and you apply it to the tumor, you're talking about an incredible ionizing, damaging force. No amount of antioxidants taken in your body is going to stop that force. It is going to just destroy whatever is in its way. And that's where the beam is focused on the tumor itself to just completely destroy that tissue. Now what happens is that radiation outside of that initial, that focal beam, there's all kinds of collateral damage that starts occurring. Other tissues start getting damaged. And there's been some interesting studies looking at what's called the bystander effect, and that the radiation gets into the blood and moves through the body, and that cells all over the body are affected by that radiation, everywhere. But the effect that happens outside of the primary site of the tumor where the beam is so much lower. That's the part that the antioxidants can start to affect and start to protect us from the damage from. It can start to quench all those free radicals that are circulating around the body, creating collateral damage in our tissues. And that's the beauty of how you can take herbs and what we call as antioxidants, things like selenium and vitamin A, vitamin E, zinc, all these kind of things that we can take. They're not going to protect, they're not going to prevent that damage from blowing up the tumor. It's like, you're putting I always think of like putting a piece of leather between an anvil and a hammer. But it's going to do a great job of helping protect our tissues around the body from that damage. And more damage to our tissues leads to more problems, more breakdown, more inflammation. So that's one of the things I wanted you guys to understand, that we can do this. We can use radiation, and we can use herbs and what are some of these so-called antioxidants, like alpha-lipoic acid, for example, in combination with radiation. Now, what I do sometimes is with people, I'll do a really strong antioxidant protocol over the weekend where I'll give them high doses of alpha-lipoic acid and N-acetylcysteine and glutamine, all these things, and really build up their network of glutathione and their free radical quenching system. And then during the day, I'll just keep them on herbs, just botanicals. And that's one way to go. And there's just a lot of discrepancy, and you look at all the research, you'll find that there's this constant battle between yes antioxidants, no antioxidants in radiation. And when you take all the research and you look at it, for me, it's really clear that if it was me, I would take a lot of herbs and a lot of nutrients during radiation. Absolutely. That's what I have come to that conclusion. I know Donnie has the same conclusion. A lot of people have the same conclusion. A lot of oncologists will focus in on a couple of pieces of research, or maybe there was some issues. And when you go back, you see some of the issues that come up with antioxidants. A lot of times what's being used in the study is synthetic antioxidants. I don't use synthetic antioxidants ever. We use naturally occurring forms. Cleaning up the mess. That's what our herbs can do, clean up the mess. So, favorable combinations with radiation therapy included vitamin A, beta-carotene, and vitamin E. This is from a 1998 study at the Seattle Cancer Treatment Center. There's so many studies. It's ad nauseum. I had the question for 10 years. It was like everybody was asking me, "Can I take antioxidants with radiation, with chemo? What do I do?" Calendula is a beautiful, plant. Topically, actually outperformed trolamine salicylate, a salicylate-based drug. Just love this plant. So soothing to the tissues. Calendula succus for the mouth and mouth sores. Great plant for using in that context as well. Curcumin and radiation protected the bone marrow, reduced radiation-induced lung fibrosis, reduced lipid peroxidation, spared superoxide dismutase and glutathione. And so treating with curcumin protects hepatocytes from damage. So again, the curcumin and I like I said before, I really like turmeric. I like to use turmeric as a whole plant compound, as a powder, and use that. You could do a teaspoon 3 times a day, and you get a lot of curcumin in there, but you get it all with the rest of the matrix of the plant. So the familiarity of the body and the functioning of all those compounds together work so much better. But it's a great thing to do with radiation to protect the cells and not affect, again, there's no way that turmeric is going to stop the annihilation of whatever's in the path of the radiation beam. Here's some more radiation protection concepts. Ginseng, it synergizes with radiation. It's actually a radiation enhancer. Glutamine. Glutamine I'm going to talk about specifically because there's a lot of, again, controversy around that agent. Melatonin, some good research on melatonin. I don't like to use the high doses very often, sometimes, but I definitely like to use melatonin in people that need help with the sleep and who get benefit from the plant, from the compound. Milk thistle, sulforaphane, we talked, this is another one of those isothiocyanates. Here's a bunch of dosing levels for you guys so you can use all of this with your patients. It's right here.
And research shows that berberine protects the cells from radiation.
Berberine as well, yeah, of course. Huang Chin, Scutellaria, Huang Lian, Coptis, Golden Seal, Mahonia, Oregon Grape, all of them. So this is another thing you can do, and this is a really cool therapy. It's a drug called Trental, pentoxifylline. You can either talk to the patient about getting it from their doctor. There's good research. This is a good study. There are more studies as well. But you do, after the radiation is completed, they take the Trental, pentoxifylline, and vitamin E, and it prevents the radiation-induced fibrosis that occurs. And the fibrosis, so the damage from the radiation to the tissue, leads to this process of the body trying to repair, basically scarring all around the area where the radiation was. And it leads to a just really, tight tissue that's not movable. Blood flow slows down. And one of the things that happens is the blood flow, the little capillaries can't pass through the fibrous networks, and low vascular areas develop. And there's no healing for those areas anymore. So the pentoxifylline, which is a derivative of green tea, it's just a subtle manipulation to the theophylline molecule. That combined with vitamin E has shown to help the little corpuscles, our red blood cells, move through the microcapillaries and get blood and nutrients to those areas, and it helps reduce that fibrosis. It's a really powerful thing I learned about from Dwight McKee that a lot of us, use in cancer therapies. So think about that for your patients, especially when the people are getting abdominal radiation to the liver. They're really important places where you need blood flow. Yeah.
Does that work even after it's been a couple of years and they've built up a lot of scar tissue for that combination?
Yeah, still use it. It's better if you can do it right away, but yep, it can still be helpful, especially if they're having a lot of issues. And the radiation-induced fibrosis will start to show up, really get going between 1 and 2 years after radiation. So you're doing this up front to help prevent. And of course, things like nodo ginseng, all of our blood stagnation relieving herbs we've been talking about, they will be very helpful as well. We want to keep those things in place.
Is there any difference between English just through vitamin E is actually just 60%, the rest is low in depth?
Yeah, the different types of vitamin E. I like the tocotrienols for sure, and obviously full spectrum tocotrienols and tocopherols together. There's good data on both sides, and vitamin E succinate is one I used to use before kind of the tocotrienols became more commonplace. But yeah, a good question. This was just alpha tocopherol in this study. Maintain the mucus layer. We talked about aloe, and it also helps to break down biofilms, which the body, the biofilms are the microbes' way of protecting themselves from the immune system. So helping the biofilms be more permeable to the immune system is important, because then the immune system can shepherd those bacteria and kind of control the populations more. Sometimes the immune system will actually escort bacteria into other parts of the body, into other tissues, other organs. That's new research. That's really cool, that we actually shepherd these organisms and bring them into other areas of the body to have them grow in those areas and affect change. Licorice, marshmallow, slippery elm, sodium alginate. This is really cool. This is a material, it's kind of like a seaweed-like material that kind of creates like a float on top of the digestive tract. It also helps to build the mucus layer, but it can prevent the acid regurg type stuff from people that are having that issue. So immunotherapy, this is where I talked about how the cancer does a really good job of telling the immune system, I'm okay, I'm you, don't worry, everything's good. And it expresses these proteins on the surface of its cell. Some of the big ones that are being targeted right now are the programmed death receptor. PDL1 is the programmed death receptor ligand 1. That's a big target for some of the drugs out there. And you've got things like Opdivo, nivolumab, ipilimumab, you've got pembrolizumab, lots of they're MABs, they're monoclonal antibodies that are large molecules that what they do is they stick to these receptors or these proteins that are expressed on the surface of the cancer cell, and then they stop the immune system from not recognizing them. They allow the immune system to recognize them. So this protein on the cell surface is sticking out. The immune system comes along and grabs onto that thing and says, oh, you're good. I feel you. You're part of us. You're me. Awesome. This drug comes in. It sticks onto those proteins, and the immune system comes along and goes, oh, I don't feel that protein. Whoa, you're cancer. Holy crap. Guys, let's get these guys. And that's how it goes. The problem is that a lot of our cells use those same proteins to say, hey, I'm good, guys. I'm part of us. So when the monoclonal antibody sticks to the normal cells and sticks to their little, safety mechanism, it's not there, and then we get autoimmune disease. So that's the main side effect. But I'll tell you what, most people would be happy to trade their cancer for autoimmune disease if it works, if it really works. Because some of these cases are pretty phenomenal, what you can see with immunotherapies. Can I keep going? I'm going to get out of time here. So, we're trying to break the tolerance and elicit autoimmunity. That's what we're trying to do with this. But as we get into these things like colitis, Crohn's disease, Hashimoto's, uveitis, and vitiligo, these are the problems. And what we can do with our plant compounds, and especially the medicinal mushroom extracts, and I'll put up a list here of compounds we can use to help this become more effective. It can also help prevent these autoimmune conditions from occurring. Here's just an idea, a quick model of how the autoimmunity occurs. These cells here, tumor-infiltrating lymphocytes, right here they're expanding, and now we have the apoptotic tumor cell, but we also see that these cells also are affecting the skin here, causing vitiligo, or affecting the eye, causing uveitis. These are common side effects of the drug therapies, the immunotherapy. So when we use our agents, astragalus, echinacea, cat's claw, all of our wonderful medicinal mushrooms, the Trametes, that's our Coriolus versicolor as it used to be called, Ganoderma, the reishi, Inonotus, that's chaga, cordyceps. All these plants are rich in polysaccharides, which have this amazing effect to help the immune system get activated, get motivated, and identify self versus non-self. We want to enhance the body's ability to identify self versus non-self clearly. Get rid of the phlegm, clear up the blood stagnation, give the immune system some good polysaccharides to chew on, and then get their vitamin D normalized, do all the things we need to do, and then we can help prevent the autoimmunity and make the drugs work better. Echinacea, 5 years in mice in leukemia, incredible research. Leukemic mice taking echinacea every day actually lived as long as the healthy mice. Really powerful research that was done. And echinacea being, this incredible enhancer of natural killer cells, and we want those natural killer cells to be activated because they're going to get out there and they're going to do their job of taking apart that tumor really efficiently. Normalizing Th1 and Th2. This is important because in some cancers Th2 may be more dominant, some it might be Th1. You can't just generalize all the time. We're not just going to push Th2. Th2 is where we see the effect from parasites, for example. Parasites develop a Th2 response, and that's why in some cultures that we see a much lower rates autoimmune disease is because their Th2 response is healthy because they get exposed to parasites. In our culture, we kill off all the parasites with all of our heavy-duty agents, and we don't have a healthy Th2 response, so we get more autoimmunity because it's a Th1-mediated condition in most of the time. It's just kind of an interesting thing that if we all got exposed to parasites a little bit more, we would actually have less autoimmunity, and that's been proven out in big studies. Medicinal mushrooms, bioremediators. They clean up the ecosystem. They do that in nature, and they do that in our bodies. They resolve phlegm. They get rid of dampness. They start to clear up the turbidity in our systems. They start to enhance our immune function. You can see I listed them here. The traditional usage data is very strong. And in all the Fujung stuff I talked about yesterday, supporting the middle, those formulas, they're all containing some of these medicinal mushrooms. Poria is up there as well. It's not in this list, but it's another one. 3 to 6 grams per day, 4 to 1 to 15 to 1, use full spectrum products, and I don't use mushroom extracts that were grown on grain. I don't do that. I use the whole plant, or the whole fungus, I should say, with the mycelium and the fruiting body grown on the medium that it naturally occurs on. Chaga, for example, Inonotus obliquus. It comes from the birch tree, right? Betula alba. And you know what that mushroom's so good at is it's got this great effect on melanoma. It really shuts down melanoma really well. And why? Well, one of the main reasons is not just the polysaccharides, but the terpenes. And there's a terpene called betulinic acid inside of the chaga mushroom. Where does that come from? The birch tree. So if you grow chaga on mycelium, if you grow chaga mycelium on grain, where are you getting your betulinic acid from? You're not. So the terpenes are really important as well as the polysaccharides. And so I use mushrooms that have been grown in their natural environment. They've been extracted with water extraction and then combined with a little alcohol extraction at the end to stabilize all the terpenes and all the alcohol extractable parts. Beta-glucans, here they are. They're nestled inside here. It's between the chitin here and the manoproteins. These are the beta-glucans. These are the compounds we're looking for. When you boil them, when you boil this stuff, it opens up those cell walls and makes these beta-glucans available. Here's the idea of these are polysaccharides from starches. A lot of these companies selling the mushrooms that are grown on grain, the mycelium grown on grain. They put them in a autoclave bag, and so they heat them under pressure, and they consider them to be really powerful because they study them for their polysaccharide content. But starches are full of polysaccharides. It's just that they look like this. What we want are the polysaccharides that look like this with branching side chains. Those are the ones that we want. That's the beta-glucans. And these are how they interact with the immune cells to stimulate immune activity, get the immune system working better. Coriolis, reishi, Cochrane metapool analysis, combining with chemo and radiotherapy, people were more likely to respond positively. It boosts natural killer cells. Here's the study. And there's a lot more research on these plants, tons of them on these fungi. So we got through that part. So we got the controversies in cancer care. My favorite part. All right. Herb-drug interactions. So I talked yesterday a little bit about what's important, and most of the drug interactions we have with herbs are all theoretical. They're done in vitro. We don't really know how it happens in the body, but when you look at the research in the human studies like I showed you yesterday, all the research showed that the plants are really helpful. They do a lot. They really do help. There are a couple of places where we have seen some interactions. Hypericum perforatum, I love that plant so much. In the case of irinotecan and Gleevec, which is a drug that treats leukemia, and irinotecan, mostly for colorectal cancer, but also in other cancers when it's indicated, hypericum was shown to increase the rate of excretion of those drugs. So it's been said never use the two things together. Well, they never evaluated whether the body's ability to detoxify, whether that actually inhibited the effect of the drug. Did it actually reduce the efficacy? St. John's Wort has a lot of anti-cancer activity and can create a lot of synergy too. So some of the studies studying St. John's Wort with chemo showed that it was really helpful to ameliorate some of the side effects like diarrhea. But we look at this interactions data and we say, well, we probably should be careful because we don't have the data. We don't know. I won't combine St. John's Wort with irinotecan because I don't want the oncologist coming to me and saying, what'd you do? You just reduced the irinotecan. So at this point, I don't have a foot to stand on, but I don't know what the real outcome is. This other one here, Velcade, a proteasome inhibitor, does interact with epigallocatechin gallate, and the green tea compound, the catechin, does inhibit Velcade from working. So I would say don't use mega doses of green tea with epigallocatechin gallate in a patient with multiple myeloma who's on Velcade. So really interesting. And the thing was, the researchers who studied it thought, this is so cool. There's this boronic acid synergy between the EGCG and the drug. It's probably going to make it work really well together, but it somehow didn't. It worked the wrong way. So that's one piece of data. And I've seen that in the clinic. So places to be careful, narrow therapeutic index drugs. That is, drugs that have a very close place between, they have a very close efficacy versus toxicity level, where the efficacy and the toxicity are almost the same. Be careful with those places because, of course, if you change the drug metabolism at some point, it could change the drug to go to the toxic level rather than being in the efficient level. That's just one place to be a little cautious. And graft rejection agents. This is another place. People who are, who've had an organ transplant and are on immune suppressant drugs. Now, of course, there's a lot of good things we can do for them, helping them, because the problem with organ transplant and being on immune suppressants is that what are you looking at possibly getting down the road? Cancer. You're looking at getting cancer because your immune system's suppressed. So there are ways we can help people, and I mean, definitely adaptogens are wonderful. I use a lot of plants with people. Plants are much better at sort of working with the body than drugs, which is tell the body to do something. So I do use plants with those people, and you just have to watch levels of drug levels and stuff, and just make sure that it's all good. But I have a lot of folks doing combinations of plants, especially adaptogens, when they're on anti-rejection drugs. Hypericum, one of the things it does is it hits this thing called the pregnane X receptor, which directs the way that the body metabolizes toxins. It's really cool because where I come from in Oregon, wherever there's a roads cut into the forest, St. John's wort pops up all over there. It just pops up everywhere. And it's like part of the repair of the natural ecosystem. And it does that so well in the body. It directs metabolic processes and helps the body detoxify. It also helps with biofilms. Again, back to that story about the immune system. And it also helps with serotonin. Induces 3A4 enzyme. This is the main pathway that drugs metabolize through. And a lot of drugs start out as what are called prodrugs, and then they're converted through this pathway into their active metabolite. That's a cytotoxic compound. And actually, in those cases, St. John's wort would increase the amount of the drug that was available. So we just, again, this plant, what is it doing? It's helping the body to move toxins through the liver. Irinotecan, combining with hypericum, this was 900 milligrams a day. Imatinib, the Gleevec, that was 900 milligrams a day. So it definitely reduced side effects, but we don't have the outcome. We don't know if it changed the pathological complete response, the overall response rate, or the overall survival, or the progression-free survival. These are big areas. We don't know what happened when we combined these things together. All we know is that we looked and we said, well, the pharmacokinetics changed. That's all we know. Good research there. Hypericum with chemotherapy is synergistic. A lot of research before, has been shown that synergy between St. John's wort and things like 5-FU. And so, like I said, I will use St. John's wort with chemotherapy, absolutely. I just have to be careful with irinotecan because of that study and because we didn't follow the research up. So green tea, the story with Velcade. This was in mice, 25 to 50 milligrams per kilogram, so it's a really high dose. 3.5 to 7 grams is what started to get into an interfering place with the drug. The severe antagonistic effect of EGCG toward the cytotoxic efficacy of bortezomib is not merely an in vitro phenomenon, but also takes place in tumor tissues of drug-treated animals in vivo. So folic acid is one of those issues, again, in cancer. Can I give my patients folic acid? Well, cancer is a situation that often occurs on what we call hypomethylation globally, meaning the body is depleted of methylators. Methylators like B12, like folic acid, like B6, like trimethylglycine, like choline. These are things that help the body to maintain the genetic transcription to happen in a way that's efficient and correct. So we need methylation. We have to have it. Gene transcription depends on it. But at the cancer site where the cancer is evolving and growing, methylation levels are hyper. It's a hypermethylating state. So we have to be a little bit careful. When I use folic acid or B12 in a patient with an active cancer not undergoing chemotherapy, I won't give them high doses of folic acid or B12 because I don't want to suddenly pour a bunch of methylating agents into a hypermethylating area. So on the other hand, if the person's on chemotherapy and you give them higher doses of folic acid, let's say you're trying to prevent their neuropathy or other things, bring down their swelling of their red blood cells, for example, with the MCV levels being high, then what you're looking at is even if the cells use that and methylated more, they would just divide faster and the chemo would affect them more. So I don't worry about it with chemo, but when it's not chemo and you're just treating someone with herbs, someone who just rejected biomedicine for whatever reason, then you have to be careful, okay? Also with the antimetabolites like 5-FU and Xeloda, the toxicity the patient experiences will be increased if they take folic acid. So don't give people folic acid when they're on 5-FU or Xeloda. It will make the drug more effective, but they're already taking a huge dose because that's oncology's way is to just go for it with big doses, kill the cancer at all costs. So they're already taking a big dose and going to get a lot of side effects. So if you increase folic acid,